Last time we were discussing neurology, we looked at multiple sclerosis, which was a really big deal. I tied some points regarding stuff we're going to see in ophthalmology later on, so I'll revisit multiple sclerosis when we see those things in ophthalmology. I also tied a lot of immunology, so you can understand that this is a type 4 hypersensitivity, that it involves Th1 helper T cells and CD8 positive T cells, right? It's really important to know that. We also looked at hydrocephalus and various differences between communicating versus non-communicating, and then a pseudo-hydrocephalus, which is the ex vacuo, where you don't really have hydrocephalus as much as you have loss of cortical brain. So we did all that. Now, right now, in this video, I'll be looking at other demyelinating and dysmyelinating disorders, as they term it. Some of these which are pretty low yield, but then the much more high yield stuff, which is neurocutaneous disorders. The neurocutaneous disorders are a lot more high yield, and NBME, step 1, everyone, they love asking questions, specifically on Sturge-weber and tuberous sclerosis, because there's just so much involved in terms of physical findings, and then anatomical findings, all kinds of stuff like that. They can give you so many different things in your question stems. So let's get this started. First thing we have here is osmotic demyelination syndrome, also known previously and more commonly before as central pontine myelinolysis. So you're losing myelin here, and majority of it is related to sodium. Massive axonal demyelination in the pontine white matter secondary to rapid osmotic changes, most commonly iatrogenic correction of hyponatremia, but also rapid shifts of other osmolytes like glucose. You would have acute paralysis, dysarthria, dysphagia, diplopia, loss of consciousness, and can cause locked-in syndrome, which is usually related to the basilar artery. Excuse me. So acute. Remember that if someone came in where they might have recently gotten some kind of correction of sodium, and all of a sudden now they have paralysis or difficulty speaking or swallowing, anything weird that just started happening all of a sudden, that's osmotic demyelination syndrome. Very, very crazy stuff that you got to be careful to avoid. So correcting serum sodium too fast will cause different symptoms depending on whether the sodium was low or high to begin with. If your sodium was low, then if you go from low to high, your pons will die. I've never had any trouble memorizing these things here. So basically, if your sodium was really low, like 122, 120, 115, 100, and you just gave them a bunch of sodium, their pons literally just, will die, because I do keep saying blow because that's kind of what sodium does, but your pons will die, and that's how it kind of dies. It blows up. So osmotic demyelination syndrome. From high to low, if your sodium was like 150, 160, something like that, from high to low, if you pulled out a lot of sodium all of a sudden, your brain does blow up. The whole brain, though. This will no longer just be the pons. Alright, so from low to high, pons will die. I always remembered low and pon, they're both 3-letter words, so that kind of helped me. Remember that it's the low to high thing that causes osmotic demyelination. It also helps me remember that I think of the pons as not having enough sodium in there, and then I threw a bunch of sodium around it, so everything came out of the pons, and the pons died. Right? The pons lost its life. Whereas from high to low, if there's a high amount of sodium and you kind of drain the sodium out, the brain just blows up because of edema stuff. Yeah, no problem. I'm glad you guys are enjoying the NBME explanation stuff. The videos are still up in that playlist for NBME 20. I haven't had any issues of needing to remove them so far, so hopefully it'll stay that way. The next stream, I just mentioned it on the community page, will be tomorrow at noon. I'll do the rest of block 4 and wrap up NBME 20. The next NBME is going to be 23 because I already wrote out the explanations for that. I am going to make other ones too, yes. I'm going to keep going with as many NBMEs as I can while I have time, because I don't really have time to sit down and do explanations, like writing it all out. But when I'm working with students, I write out explanations. So as I do that, I can use the same explanations for the videos as well. So that's the plan there. Now, when I was doing one of my rotations, one of the doctors had actually asked me if I knew how to correct sodium, and I didn't, right? So this is the equation over here for corrected sodium, right? So this is like how you figure out the numbers and stuff. Not something you'll necessarily need to know, but I just put it here just for you to see it. So glucose is related. To actually correct sodium, this is how you do it. So, to correct low sodium, you infuse 3% saline with the goal of increasing sodium by 6 to 8 milliequivalents per liter in the first 24 hours, or 18 milliequivalents per liter in 48 hours. Right? Consider 1 to 2 mcg desmopressin every 4 to 6 hours. So this is something really significant to know. NBME, I've been seeing lately, loves throwing in 3% saline, 5%, 9%, all of these like numbers out there. If you've never heard of those percentages, you'll kind of be out of nowhere. To correct high sodium in a patient who's way over the normal range of 135 to 145, you infuse dextrose, right? So now you're going to be giving them sugar. Alright, so you infuse dextrose for acute cases, or 0.45% NaCl for chronic cases, with the goal of lowering serum sodium by just 0.5 milliequivalents per liter per hour, aiming to lower 12 milliequivalents per liter per day. Right, so it's a very intricate way of doing it. You're not going to per se remember these numbers unless you look at it every day, talk about it very commonly. But however, you can go ahead and just remember what whatever method you like remembering things with, so that when you see, just remember it enough so that when you see the answer choices, it should ring a bell, right? So to correcting low sodium, there's a lot of factors of 6, right? 6, 24, 18, 48, multiples of 6, I mean. And to correct the high sodium, just remember the 5% dextrose. That's all you really need to remember. Otherwise, everything else is 0.5. So basically 0.5% NaCl, 0.5 milliequivalents per liter per hour. And then, that's basically all that we're working with here. So that's osmotic demyelination syndrome. Pretty nice topic, does get tested. Usually it'll be very evident that this is what's happening. The question will tell you that, there was an issue with sodium, they corrected it. They won't tell you how they corrected it, or maybe they will tell you how excessively they corrected it or how quickly they corrected it. And then based off of that, what can you do now once the issue has occurred? Nothing. You can't do anything. Once osmotic demyelination syndrome occurs or cerebral edema herniation occurs, you can't really necessarily do much. You have to just provide symptomatic relief until everything normalizes by itself. Alright, so it'll normalize by itself. Stop correcting it, obviously. And then just wait for it to go back to normal levels by itself. The next topic, this one sounds a lot like something NBME would love asking about, but I've almost never seen a question about this. Acute inflammatory demyelinating polyradiculopathy. Most common subtype of Guillain-barre. Guillain-barre is a very high-yield topic. Autoimmune condition that destroys Schwann cells via inflammation and demyelination of motor fibers, sensory fibers, peripheral nerves, likely facilitated by molecular mimicry and triggered by inoculations or stress. Despite association with infections, no definitive causal link to any pathogen. Results in symmetric ascending muscle weakness paralysis and depressed or absent deep tendon reflexes beginning in the lower extremities, which is very characteristic of Guillain-barre. Facial paralysis, usually bilateral, and respiratory failure are common. May see autonomic dysregulation, such as cardiac irregularities, hypertension or hypotension, or sensory abnormalities. Almost all patients survive, which is great. Majority recover completely after weeks to months. There's going to be high CSF protein with normal cell count, right? So this is called albuminocytologic dissociation. This is really important to know that, right? Albuminocytologic basically means that it's just all protein. It's not an increase in cell count. It's not that there's more cells or anything. There's just more albumin. You could think of it like that. Right, so high CSF protein, but normal cell count. There aren't any bacteria. So the sugar count would also be normal. Usually when you have CSF bacteria in your CSF, your glucose goes really low because the bacteria start using it up. Respiratory support is critical until recovery. DMTs, like a disease-modifying treatment, are going to be the plasmapheresis or IV immunoglobulins. Do not give steroids. Right? So these guys with acute inflammatory demyelinating polyradiculopathy, although this is autoimmune, you do not give corticosteroids. Nor do you need bacteria-killing antibiotics. Neither of those things. The only thing they need are IV immunoglobulins, right? IVIG, and they'll be fine. It's all going to self-resolve. The most important thing to give to them is respiratory support. Right? And then remember the phrase albuminocytologic dissociation. That is something that is pretty much defining of this subtype of Guillain-barre. The next thing, acute disseminated post-infectious encephalomyelitis. Multifocal inflammation and demyelination after infection or vaccination. Presents with rapidly progressive multifocal neurologic symptoms and an altered mental status. Very rare little thing. I think the only way this would really present in a question would be someone that just got their vaccinations for something, and then after the vaccination they started having neurologic symptoms. If you see that, you should think of disseminated encephalomyelitis, right? Post-infectious encephalomyelitis. The number one cause of sporadic encephalomyelitis is just HSV, mainly HSV1, right? So that's another thing. That's different. But here we're seeing post-infectious encephalomyelitis, more than likely something related to a vaccination that's going to occur causing demyelination. Of all of these, though, I feel like the most high-yield topic so far was osmotic demyelination, and then the next one is this guy, CMT, Charcot-marie-tooth disease. Not something that I think NBME necessarily tests you on, but it can be on your step 1, and I don't know if I've ever seen a Euro question, to be honest. So CMT, also known as hereditary motor and sensory neuropathy, group of progressive hereditary nerve disorders related to the defective production of proteins involved in the structure and function of peripheral nerves or the myelin sheath, typically autosomal dominant and associated with foot deformities like pes cavus or a hammer toe, lower extremity weakness, so foot drop, and sensory deficits. The most common type, CMT1A, is caused by a PMP22 gene duplication. So I have a couple notes here. I memorized CMT to stand for can't move or touch, more so can't move or sense anything. Right? There's motor and sensory neuropathy. So that should immediately, when you see someone with motor and sensory neuropathy in a weird way, you start thinking of Charcot-marie-tooth. And then PMP22 is peripheral myelin protein 22, which is actually found in the peripheral nervous system. It connects the brain to muscle and sensory cells. So if you have a gene duplication of it, that's pretty much a mutation. It's going to have an issue with that gene. It's not going to work too well, and that's where you start getting Charcot-marie-tooth symptoms. Alright, so it's a weird thing. I haven't really seen many questions on it, to be entirely honest, but this page is just full of mixed things. So it's just, they are all classified under demyelinating or dysmyelinating disorders. This one we've seen a lot. PML, progressive multifocal leukoencephalopathy, is related to JC virus mostly, so demyelination of CNS due to destruction of oligodendrocytes, secondary to the reactivation of latent JC virus, seen in 2 to 4% of patients with AIDS, rapidly progressive, usually fatal, predominantly involves parietal and occipital areas. Visual symptoms are common, and there's an increased risk associated with natalizumab. This increased risk with natalizumab is the most piss-off little sentence they could have put here, because you get a dumbass question where someone is taking natalizumab, and then all of a sudden they present with this. Right? So if you have that, you should be able to make this connection. Just keep that in mind. JC virus has another virus in the same family called BK virus. I always remember them as JC for just chilling. So they are just chilling. They can't do much because they have this brain damage. And then BK for bad kidney, which actually does cause kidney injury. And those guys in microbiology, let's take a look at it real quick. Virology. Let me see if it pops up. JC. Yeah. Okay. So those guys, because they do become latent, you should keep in mind. Yeah, right here. So they're polyoma viruses, right? They're double-stranded and circular DNA viruses that become latent, right? And latency is mostly a DNA virus thing, just like the herpes viridae. A lot of them become latent. Actually, almost all of them do. So JC virus, progressive multifocal leukoencephalopathy and HIV, and BK virus causes issues in kidney transplant patients. All right, so that's something you want to keep in mind. They have junky cerebrum and bad kidney, altered mental status, motor deficits, limb and gait ataxia, and seizures. And then other disorders are also things we saw already in biochemistry under metabolism issues, right? The Krabbe disease, metachromatic leukodystrophy, and adrenal leukodystrophy. Adrenal leukodystrophy, remember, was the one related to adrenal gland, white blood cells, and dystrophy. So keep in mind what those diseases are. If you forgot them, you should go back and take a look at them wherever they are throughout the book. They're in the principles. And adrenal leukodystrophy had its own place somewhere, I think, in immunology. So now here we have an AMBOSS question. This one says, a 6-year-old boy is brought to the physician by his parents because of right lower extremity weakness, worsening headaches, abdominal pain, dark urine, and an 11-pound weight loss for the past 2 months. His teachers report that he has not been paying attention in class and his grades have been worsening. He has a history of infantile seizures. Physical exam shows a palpable abdominal mass and left costovertebral angle tenderness. Neurological exam shows decreased strength of the right lower limb. He has several acne-like angiofibromas around the nose and cheeks. Further evaluation is most likely to show which of the following. So he has several acne-like angiofibromas. Up to that point, it was a little sort of hard to figure out what's wrong with this kid. And then you got the angiofibromas, and it was a giveaway. As soon as you saw that, it was a giveaway. The only other thing you might see from those answer choices, there's many other things you could see, but from those answer choices, subependymal giant cell astrocytoma was the only one you could pick. The boy's combination of facial angiofibromas, signs of angiomyolipoma because he has the abdominal mass and macrohematuria, a history of infantile seizures, and signs of potential brain tumor because of the decreased limb strength and declining performance and attention, all indicate tuberous sclerosis. Very high-yield topic that's on the next page you have to keep in mind. Subependymal giant cell astrocytoma is a brain tumor associated with tuberous sclerosis. Other common manifestations of tuberous sclerosis that this patient could develop include shagreen patches, ash leaf spots, benign cysts, and renal cell carcinomas. There's a lot of associations that you have to make sure you memorize. So the next page starts talking about neurocutaneous disorders, and these guys are much more high yield than the stuff on this page. Right? So don't spend too much time trying to master the stuff on this page. Just understand CMT, understand JC virus because it's already related to something you talked about in microbiology. Keep in mind that for this thing related to Guillain-barre, all you do is give IVIG and respiratory support. And fixing sodium, you do very, very slowly. No matter where, high or low, you do it slowly. So the low to high your pons will die is the one that kills your pons. The other one kills your entire brain. Now, neurocutaneous disorders. All of these are autosomal dominant except Sturge-weber. But since we just did a question on tuberous sclerosis, let's take a look at that. So it's autosomal dominant with variable expression. Right? This is a genetics thing. Variable expression expresses differently. TSC1 mutation on chromosome 9 or TSC2 mutation on chromosome 16. And TS is going to help you remember it's a tumor suppressor gene. You start getting all of these things which fits this, but I never really used this because it was too many things. The only thing that tuberous sclerosis can help you, the only thing hamartomas can help you remember from tuberous sclerosis is the M should remind you of mitral regurgitation, and even that'll only really happen if the question mentioned a murmur, and you're trying to figure out what the murmur is, mitral regurgitation. Other than that, you're going to see hamartomas in the CNS and skin, angiofibromas, which looks like this, right, so image C. Let me see if I can fit this together. Yeah, okay, we can fit most of it together. Ash leaf spots, which looks like this, so white spots, right? Cardiac rhabdomyoma, which we've seen in cardiology. Autosomal dominant, mental retardation, and then you can get a renal angiomyolipoma. And you can see how there's a lot of lipid in this histological image here, and they'll tell you that it came from their kidney. Right? Other than that, seizures and shagreen patches. Shagreen patches look like this. It's actually weird skin, kind of feels like hives, right? And that's your shagreen patch right here. Most commonly in the lower back, a leathery texture hamartoma of connective tissue. They didn't have an image of shattered green patches in the book. All right, but these are your angiofibromas, and this is your ash leaf spot, and angiomyolipoma. All three of these things are things you see in tuberous sclerosis. You also have an increased incidence of what our question was about, the subependymal giant cell astrocytoma. The other thing is an ungual fibroma. It occurs in your finger, right, under the nail. So that's your ungual fibroma. This is a subependymal astrocytoma. We haven't looked at brain tumors yet. That's going to be in the next video. We're going to look at adult and childhood primary brain tumors. So that was tuberous sclerosis. The other really high yield topic is Sturge-weber syndrome, which is very much going to help you also. I used to think of this and varicella zoster similarly because they're both on one side similarly, right? So both of these things occur on one side. This is a congenital non-hereditary, right? Non-hereditary anomaly of neural crest derivatives, which is why it's another reason why it's so high yield, neural crest. You get somatic mosaicism of an activating mutation in one copy of the GNAQ gene. GNAQ is guanine nucleotide subunit alpha. That's the thing you're having a mutation in. This affects capillary-sized blood vessels. So if you get a question on what size blood vessels, capillary. It's affecting the tiniest guys. Capillary-sized blood vessels, leading to a port wine stain, also known as nevus flammeus or non-neoplastic birthmark. So image A. As you see, it has only on half the face, and it's kind of in the distribution of V1, V2. Right, so it doesn't go to the V3 distribution. It's only on the upper lip, not the lower. So in the V1, V2 distribution, ipsilateral leptomeningeal angioma, which is in image B. So you see this is a leptomeningeal. It's affecting the meninges, and it's an angioma in the brain. That can cause seizures, epilepsy, intellectual disability. Episcleral hemangioma is another thing you can get. Episcleral is going to be on top of your sclera in your eye. That causes an increase in intraocular pressure, leading to early onset glaucoma, right? Intraocular, inside the eye. All of this is going to be really problematic in a young child, and you're going to have to pick Sturge-weber as your answer choice, or the fact that this is just a mutation in GNAQ. Also known as encephalotrigeminal angiomatosis, right? The tram track calcification of opposing gyri looks like this. So this is your tram track calcification that they're talking about. Right? Glaucoma, epilepsy, and seizures and stuff like that. You're going to get a patient who's presenting with a weird constellation of symptoms for both questions, Sturge-weber and tuberous sclerosis. As long as you can connect the constellations, you can pick the right disease. Right? So tuberous sclerosis is a tumor suppressor issue, so they're going to have many tumor kind of things, whereas Sturge-weber is just going to have the glaucoma and epilepsy in a young child. Right? And when you see glaucoma and epilepsy, you have to think of Sturge-weber and figure out the fact that they probably have that stain on their face, which is just a birthmark, and it's not cancerous. There's nothing cancerous about here except for these two things, the leptomeningeal angioma and the episcleral hemangioma. The last two, or there's three, okay, so these next two, they're both neurofibromatosis. The first one is NF1. It's autosomal dominant with 100% penetrance. It's going to be a mutation in the tumor suppressor gene on chromosome 17, which encodes for neurofibromin, a negative RAS regulator. You're going to start seeing cafe au lait spots, which looks like this. Right, cafe au lait spots, intellectual disability, cutaneous neurofibromas, the defining feature, Lisch nodules, which are pigmented iris hamartomas. Right? So this is another little thing that we also sort of connected to Down syndrome way in the beginning. Optic gliomas, pheochromocytomas, seizures, focal neurologic signs, and bone lesions like sphenoid dysplasia. Right, bone lesions. So the patient might initially actually present in your question because of symptoms from the field, hypertension. Right, and that's going to try to throw you off. Then they might even mention after that sometimes when he has really high blood pressure, he also gets seizures. They're going to try to make you think that the hypertension is causing seizures. And there might be one giveaway is probably a cafe au lait spot, or they'll mention that last year he had an optic glioma or something. All of that comes together, and you go ahead and pick von Recklinghausen disease. That's the other name for this disease, right? It's NF1. Right? The cutaneous neurofibromas are benign nerve sheath neoplasms predominantly comprised of Schwann cells, which are derived from neurocrest cells. All right, so you can also have a question on that the cutaneous neurofibromas are a derivative of what? Right, and then don't pick ectoderm, pick neurocrest cells. Next thing, neurofibromatosis 2. It causes things that are pretty much bilateral. So the 2 is fitting here. It's also a tumor suppressor gene. You get bilateral vestibular schwannomas, juvenile cataracts, meningiomas, and ependymomas. Right, so really significant cancers. And let me see, I think I had some pictures. Oh yeah, we're going to see more of it later on. Okay. Right, so this is an acoustic schwannoma, and that's pretty high yield topic right there. We'll look at it later. So that's NF2. Von Hippel-lindau disease is the last. There's 3 things on this page that are kind of like a constellation of cancers or something. There's the Sturge-weber, tuberous sclerosis, and von Hippel-lindau. VHL is a deletion of that gene on chromosome 3. The protein actually ubiquitinates hypoxia-inducible factor 1A. If you don't ubiquitinate it, you won't destroy it, and then you end up having too much hypoxia-inducible factor 1A. So you end up having hemangioblastomas, right? High vascularity with hyperchromatic nuclei in the retina, brainstem, cerebellum, and spine. So here they're showing you hyperchromatic nuclei. Okay, and you do notice the really dark dots. Those are hyperchromatic nuclei. And hemangioblastoma in the spine. Right, so weird tumor kind of thing in the spine. That's a sign for VHL. You also get angiomatosis and bilateral renal cell carcinoma. Right, bilateral renal cell carcinoma, as well as pheochromocytoma. So VHL, HARP is one way to remember it if it helps you. But notice that these questions are really, these disorders are really awesome for any test writer, because they can ask you questions in so many diverse ways. And these questions can start off anywhere and then lead to a connection of a bunch of other things. And if it doesn't ring in your mind that it's probably VHL or if it's probably TS or SW, then you're going to be really lost and you're going to pick the wrong answer choice. So make sure that you're able to see enough symptoms before you actually lock in VHL. Right? Just because someone with pheochromocytoma also has a hemangioblastoma doesn't mean that you're just going to pick pheochromocytoma as an answer choice. No, it's actually VHL. And they probably also have other things. Alright, so be very careful in that. But also don't overthink. Don't overthink either. So interesting disorders, really unfortunate disorders, and they're all autosomal dominant, so there's also going to be times where you're going to see family history. The only thing that wasn't congenital was Sturge-weber. This is just a somatic mutation. Right? Somatic mutation. That means that the parents didn't have any issues. This occurred in the infant itself, and a few of the cells are all messed up. Somatic mutation, not a germline mutation. Alright, so that's basically it for that. In the next video, I'm going to make a separate video for this where I go into your adult and childhood primary brain tumors, which are really high yield things, often taught with or tested with images like this. So you have to be able to associate these images very well to each one of the various cancers or brain tumors that we're looking at. All right. So thanks a lot for joining, and I'll catch you guys later on.